And now, Michael Raisman will present Thermokeratoplasty with Crosslinking for Myopia. Can it compete with laser vision correction?
Thanks, Marguerite. It's a pleasure to be here and give you an update on thermokeratoplasty, which I presented to you last year. We've had another year of experience. I should point out I'm a consultant for Avedro. I do have a financial interest, and I'm one of the investigators for their cross-linking FDA trial. I'm going to talk about the use of heat through a microwave application to reshape the cornea for a variety of indications, including myopia. The Keraflex system refers to this microwave technology. It's not available in the US, of course, because we're light years behind the rest of the world. The device has been approved with CE mark in most other countries, and the devices have been used now in the various countries listed here. The procedure involves an annular application of microwave energy to flatten the cornea in combination with collagen crosslinking. And the crosslinking is important because otherwise the cornea tends to resume its desired original shape after reshaping. Here's the current iteration of the system. A suction ring is placed on the eye. The microwave application device is applied. The treatment takes less than 1 second. Electrodes deliver the energy. You can determine the diameter, the depth of treatment. You can cool the surface to preserve epithelium if you like. All of these are adjustable. The energy is produced and the cornea is heated. Here's a picture immediately after the application of an annular ring on this patient with myopia. Looking in an animal eye, you can deliver the energy. It creates a scar, as you see here. This is a very intense treatment. Here's the histopathology afterwards. Here's a human eye bank eye showing the types of energy we actually deliver to the human cornea, showing the intact epithelium with a mild scar formation just beneath in the anterior stroma. Here's a myopic patient 1 day after the treatment. You may be able to make out the slight opacity in a circle here. This disappears after about 1 week. It's not detectable at the slit lamp. Here's a myopic patient. This is actually the pre-op in the center. Attempted correction was 2.8 diopters. 2.25 were achieved at 1 week, but this patient was not cross-linked and regressed back to the original corneal shape and refractive error after about 3 months. So you have to combine this with cross-linking. By adjusting the parameters of delivery, you can actually get a quite predictable change in the shape of the cornea. So this can be quite effective for altering the refractive error. The long-term results are not known with this technique. One thing that might be desirable is to treat, allow the patient to regress, overtreat, allow the patient to regress to the point where they're satisfied with the vision, where you've achieved what you want, and then cross-link at that point to stabilize. Another interesting effect is that some of these patients can achieve a multifocality of the cornea, and it may be a way to provide some presbyopic correction as well for these patients. Clinical trials are obviously needed. I'm more interested in the application of this device for treating keratoconus, where I think it has tremendous potential and we're gaining experience. There have now been over 200 keratoconus eyes treated outside the US, with about 30 of them with 6 months of follow-up and some with almost a year of follow-up that I'll show you later. The safety has been outstanding. 2 eyes lost 1 line of best corrected vision. There's been no adverse vision loss in any of these patients. The flattening does correlate with the energy applied. Most of these eyes are now being cross-linked at the same time of the treatment, but there may be some advantage to delaying cross-linking till after. We don't know yet. The results have been surprisingly good. The haze is really minimal, lasting only a few days. There have been no induced ectasia cases. Epithelium's healed well in all cases. No infections have been observed. The discomfort is minimal, not different than cross-linking with epithelium off for the patients who have that procedure. What about stability? We don't have enough follow-up yet, but I'll show you some impressive results. Is it possible that more intense cross-linking, as can be delivered now with the Avedro UV device, might be better for these patients? We don't know. We're trying that. Some of these patients are now being treated with 3-minute treatments rather than the longer duration UV light treatments. And some of these patients treated with higher UV energy are actually showing progressive flattening over months. Here's a patient with a mild cone. You see the pre-op, post-op, and then a difference map on the back with the nice annular flattening. Here's a more dramatic cone. You can see from the difference map, there's excellent flattening of the cornea. What's interesting with this device, although the treatment is annular, you tend to get an increased effect in the steeper areas and less of effect in the flatter areas, which is of course desirable. Here's a patient who had the right eye treated with cross-linking alone for keratoconus. You do see some flattening, as Bill Trattler showed you in some of his cases. This is common to see a little bit of flattening here 3 months out. The opposite eye, though, the patient had a much steeper cone. As you see here, for those of you who can't see, the steepest is around 73 diopters in the center. This patient was heading towards keratoplasty, instead had Keraflex and then cross-linking, and had dramatic flattening, as you can see here. Here's the patient 6 weeks out. Look at the change in the refraction and the visual acuity with the cross-linking and Keraflex procedure. Happy patient, needless to say. I'll show you a few other cases. Here's immediately after treatment, 1 week out, 6 weeks out. Dramatic flattening, and more examples. I don't have time to show you those in detail. I did want to show you a few cases that Arthur Cummings shared with me. He's treating patients in Dublin, and he now has almost 1 year of follow-up on some of these keratoconus patients. So we can start to see that we are getting good stability and long-term effect on these keratoconus patients. Here's the immediate difference maps on some of these, and these are very steep cones. Some of these patients were not tolerating a hard lens anymore and were considering keratoplasty. Here's one patient almost a year out. Here's the pre-op, 3 months out with a beautiful, regular, small amount of astigmatism centrally, a very regular topographic appearance now. 6 months out, good stability. 11 months out, good stability. Still excellent visual acuity with spectacle corrections. Here's 4 patients that have at least 6 months follow-up and now almost a year. These patients were cross-linked about a month after the Keraflex procedure. Again, we don't know the optimal time to cross-link, but here you see a dramatic flattening with Keraflex, initial regression, and then cross-linking, which provided an additional effect and then stability over 6 months. This is the average Ks on these patients. You can see a dramatic reduction in average Ks. If you look at Kmax, a similar pattern on these patients. So in summary, Keraflex can produce tremendous flattening and regularity to keratoconus corneas. Whether we should do the cross-linking at the same time or later is not clear, but cross-linking is essential in making this work. And not only is there flattening, but there's a better corneal shape after this combined procedure. There's other ways to treat these keratoconus patients with rings, PRK, but even the worst cases that we've seen with Keraflex have been superior to these other modalities for the severe cones. So I'm optimistic that collagen cross-linking plus thermokeratoplasty may be excellent treatment for the majority of our keratoconus patients in the future. Thank you very much.